All right, airway management and vent. So a lot of this should be kind of review because it's how it applies to that acute respiratory failure. So what is it? It's a tube in the trachea, either by the mouth or by the nose. And it basically bypasses the upper airway, so the laryngeal structures. Let's see what I got in here. There it is. Tube. It bypasses, so it goes in the nose or it goes in the mouth, and it bypasses, I know this is humongous, the laryngeal, right, into the lungs. Should I, like, lecture the whole time just like this? So why? Either because we have some kind of obstruction there. Patient's apneic, they're not breathing. They're at high risk of aspiration. Or they're in respiratory distress. Or can't clear their secretions.
Are you threatening us with that? Or?
No. I'm really excited because I forgot to request it, and the night people did, so I'm stealing their stuff. I know. I forgot I'm recording. I love you, night people. All right, so what are the benefits? It secures a rapid airway in an emergency. And because we have a big diameter tube, it decreases our work of breathing. But what are some risks? We chip the teeth. So when we insert it, we definitely oftentimes chip teeth. So, oh, these are not even the right size. Okay, normally this clicks in here and opens up. And then we go ahead and insert this. Yeah. So you take this, you put them in the sniffing position, open their mouth, and stick that in. And you lift up. That way you can see the vocal cords and you go in between the vocal cords, okay? All right, so imagine this big old honking heavy thing, you know, when you're pulling up, it's very easy to chip a tooth. Oh, I'm so grossed out, I have like... All right. It makes it hard to swallow, right? Because you have this tube in your mouth, and your mouth, you have secretions. So if you have this tube, you can't swallow. So secretions develop. And patients can obstruct the tube by biting down on it. That's why oftentimes you see bite blocks, because if they clamp down on it. And mouth care is a challenge. All right, so we talked about the ET tube already. You will have, I believe all adults are cuffed, but peds can be cuffed or uncuffed. So this is the cuff right here. I'm just going through their stuff. I need to, no. There we go. All right. So you'll take a syringe. Once it's inserted, they will go ahead and inflate the, oh, maybe they won't. But you see how it blew up a little bit if it was a functional ET tube? Can you see it blowing up? Mm-hmm. Okay. So they'll insert it, deflate it, and then they'll blow it. You can see it deflating right now. They'll insert it, deflate it, and then they blow it up. That kind of keeps it in place, okay? So that's what this little part here is for. This is just the stylus. This just helps guide it. Once you're in, then it makes it a little bit stiffer, so it's easier to insert. You'll take that out. And then we typically put a CO2 monitor right on top. And most hospitals have the purple and yellow. Yes.
Is that metal thing you have just to open it up?
Yeah,
Because
that's-
you're putting it in a weird way. I thought it would go the other way.
No, it's, and this is not the right, oh, there it goes. So it will actually have a light at the end, and you guys aren't licensed to put these in. I do it as a nurse practitioner, physicians do it, EMTs will do it. That what? What was your question, Maria?
My question was, do NPs do?
Yeah, I do. So this is meant to go in and lift that upper palate, lift that upper airway up so that you can see the vocal cords. So when you click it on, but your job as the nurse, they're gonna ask you to grab the laryngoscope. It comes like this. You've gotta understand that you need to click it when they actually fit and put it open and make sure that the light works. Because if it doesn't, it's gonna be your job to quickly get a new one with the light that works. All right? So when you're getting, if someone says prepare to intubate, you're going to get this, you're clicking it, you're saying, okay, my light works, and I've got my tube. All right. Once they insert it, like I said, they'll blow up the balloon, and that helps keep it in place. And then they're gonna check placement, which we're gonna talk about by putting the CO2. So prepping it, consent. If they're awake, if they're with it, they need consent. It's a procedure. We're going to teach them. They're going to have a tube. They're not going to be able to talk. We'll provide communication or teach the family that they're not going to be able to talk, that we're still going to monitor pain, that we're still going to take care of them. They go in that sniffing position, like I said. And the attempts only last 30 seconds. When you are sticking this tube in, they aren't breathing. Right? So are you going to go longer than 30 seconds? With attempts, because that whole time they're not breathing, so they're not getting oxygen. So we want a bag Malvas, that's BMV, bag Malvas, before and after at 100%. Yes, Tony?
Are they sedated during this time?
Yeah, sometimes we give sedation. Yeah, a lot of times we give sedation. A lot of sometimes they don't need sedation because they've got like a head injury or something, but yeah, we sedate them. We're not mean. Bag valve mask. So, oh, here it is. Yay, I found it. Oh, it's probably BVM. I'm sorry. My dyslexia. Bag valve mask. That's the ambu bag, right? Okay? So, a lot of times they have the face mask. So you're going to put the face mask over them. Bag valve mask until they're at 100%. Attempt intubation. If you're successful, you attach your CO2 and you bag valve mask your CO2 monitor. Okay? It's going to turn, I honestly forget. I don't know if it turns purple or yellow. I can't. Does anyone remember? It changes color. Whatever color it comes, it's going to change. If it's yellow, it's going to change to purple. If it's purple, it changes to yellow. It will change color. If it changes color, that means you have CO2. Is that good or bad? It's good, right? Because that means that you're in the lungs. If it doesn't change color, then that means you're not getting CO2. It means you're not in the lungs. Okay? So you put it in, you attach the CO2 monitor, you bag valve mask here to 100%. And then you're going to typically take this off and attach their vent. That makes sense, everyone? All right. So you need O2. There, see, I put it right there. Bag valve mask, BVM. Suctioning equipment, IV access. If it's an RSI, rapid sequence intubation, then we do things like sedatives, paralytics, opiates. Most people are RSIs out on the field. So they get Versed, fentanyl. Tonia, can you close that?
What's RSI?
Rapid sequence intubation. So the best way to see that it's in the right place is the CO2 detector. It's the best way, initially. Where did it go? Wherever it is, that's the best way. Okay? So how do we confirm it's in the right place? That in title, CO2 is the best way. Because you're going to see immediately that it changes color. If it doesn't change immediately, you're not in the right place. So if it's not in the right place, what do you think the doc's going to do?
Take it out.
Take it out, right? And then are they going to retry right away?
No.
No, they're going to sit there and bag valve mask until 100% and then reattempt. Yes.
That thing is something visible on and off.
Yeah, it literally, this is it. This is what it looks like. And it comes in its own little bag. And I'm sorry I'm blanking on the color, but it comes one color and it will change to the other color. Yes.
What were you talking about when we moved on to?
Huh?
I'm not getting breast sounds on one side. Don't they just reposition rather than take away?
I'm not there yet. I'm saying if they put the CO2 on and they don't get a change, then they're going to take it out because that means that they're not in the right place. They might be in the stomach. They might have gone down the instead of the trachea, they've gone down the esophagus. All right. So other things, obviously we hear breath sound. Yes. Bite block. So once we have the CO2 detector, we can listen to the lung sounds. We want to make sure we hear lung sounds equally. This is where, when we put it in, which bronchus is longer, right or left? Right. So a lot of times what happens is we go down too far. So we're only ventilating the right side. So we need to make sure that we hear equal breath sounds on both sides. If they're not equal, we may need to just pull it up a little bit to make sure that we're ventilating both sides. Chest wall movement, right? If I see my chest wall moving on both sides, that means I'm breathing. Obviously, if we have a good O2, then we're going to secure the airway. We put a bite block in because one of the complications is that they bite down on it, right? So the bite block just keeps it so that the patient's teeth can't bite down on it. We may need to suction in the tube and in the mouth. Chest x-ray will confirm placement. And it's 2 to 6 centimeters above the carina. So that just tells us that we're not going all the way into the right main stem. That we're kind of keeping it up high enough so that we're ventilating both the left and the right side. And then we mark the tube. So if you can see on the tube, and I'll pass it around, and you can see the cup, there's little like markings on it. You want to mark where that is. Because if they're at 22, and then all of a sudden you come in and it's 26, and your patient's in respiratory distress, you know, oh crap, it's too far in, right? So that I may need to pull back a little bit. And then,
This might be a stupid question, but
no stupid questions.
if that happens, do you, like, deflate it? Or just-
Yeah, you'll have to deflate it to move it. Yeah, because the thing about it, we've got the airway.
Anyway, but
Yeah. So this is your airway, right? Your trachea. When you put the tube in, this is the tube. Okay, it's smaller than the airway. There's 2 reasons we put that the cuff. We inflate it. When we inflate the cuff like this, it's going to help any secretions that come down not get into your airway. And then the cuff is going to make sure that everything we give them O2-wise stays there. Because if we don't have that cuff inflated, the O2 that's coming down here can then leak around it, right? So there's 2 main reasons that we inflate that cuff. So obviously, if the cuff is resting against that wall, we don't want to be, you know, like rubbing against the mucosa and irritating it. I feel like I just did a bad gesture. Okay, so when we tape an ET tube, how many of you should be there to tape an ET tube? 2. So typically you do a nice big long strip, okay? And then, because this is, again, you're not going to be intubating, but you're going to be preparing all this. Is this something you want to do once the patient's intubated, or do you want to do it before? Then you're going to take another strip and you're going to make it a little bit less. And you're going to put sticky to sticky. Okay? Sticky to sticky. Now this part's not sticky. I think last time I did this I got stuck in my hair. Okay. So then you take, oh, you don't do that. You tear a little piece like this, right? This is not the best tape. You would not have paper tape. You'd be like having real tape. Tape like this. And tape, oh my Lanta. Tape like that. Oh, this is the worst tape ever. Okay? Then you put it behind the patient's head. And with the little tube, this is, I hope no one's videotaping me. So, right? You're going to wrap it from the top around and then the bottom, okay? Does that make sense to everybody? Okay, and you can see it up here. Right here, you put one piece above their lip to secure it, and then the bottom piece you wrap around, and then you're going to come over here to this other one. Again, you put the top piece over your lip, and the bottom you wrap it around. Got it? Okay. All right, so in your book, it goes into like big depth about stabilizing and sealing the ET tube. And it talks about on page, I think it's 1615, it talks about the two different ways. So we want cuff pressure, because like I talked about, oh, it's not going to let me, where's my pen? I should have done this before. Okay, no one freak out. It's going to go away for a second. I know, no one freak. It's okay. I have to do my pen. Is it still there? No? Uh-oh.
Now should I freak out?
Yeah, now you might want to freak out. It's coming back, right? There you go. Okay, so again, we have our airway, right? And then we have our tube going in. And we have the cuff. So the cuff creates this seal. That way we don't have any O2 escaping and we don't have any secretions coming down, right? So we want to stabilize it. If we have that cuff too high and it puts too much pressure on the mucosa, it's going to break down that mucosa. And we're going to get ulcers that form. Those aren't good. So we check the pressures. And they do it two different ways. They either inflate it until they don't hear an air leak anymore, or they deflate it until they hear a small air leak. Don't worry about that too much. You're not ICU nurses. I would understand that if I had someone that had an ET tube, that they're at risk for mucosal damage. Oh, it sounds like a care plan. Right? So that they're at risk for that mucosal damage if the cuff pressure is too high. All right. So they measure it frequently. Oh, it's okay. It's going to be, it's all right. So, oxygen. How do we're going to measure oxygen by ABGs, right? Specifically the PaO2. So again, all those signs of hypoxemia, like mental status changes, dysrhythmias, right? When we have decreased O2, what does the heart doesn't like that, right? When the heart's not getting oxygen, it starts to act funny. So we might see some dysrhythmias. That's a sign that our patient's not tolerating. Dusky skin. If we're monitoring ventilation, then we're monitoring the CO2, right? Oxygenation, O2, ventilation, CO2. So a patient can be hyperventilating. If they're hyperventilating, what is their respiratory rate? High. I'll give you a hint. It's all on the board already. Okay? If they're hyperventilating, respiratory rate's high. If the respiratory rate's high, what's happening to your CO2? It's going to go low, right? Because you're blowing it off. Blowing off. What happens to your pH? Because CO2 is acidotic, right? So if you have decreased CO2, decreased acid, your pH is going to become more alkalotic, right? Versus hypoventilation, and this is where ABGs become important. You have decreased respiratory rate, right? Hypoventilating, low respiratory rate. So, very slow. So you're retaining CO2. So your CO2 is high. And we said CO2 is acidotic. So if you have a large amount of CO2, what's happening? Where's your pH going? Right? Down. Acidotic. So these are the things that we want to monitor respiratory rate, right? Because that's going to make a big difference. So if I notice that all of a sudden my patient had a respiratory rate of, 16, and now all of a sudden they're blowing, their respiratory rate's up to 30, in my mind I'm thinking, okay, they're blowing off CO2, they might become alkalotic, what am I going to be looking for? Or how can I treat them? Are they using any accessory muscles? Because again, when we talked about respiratory failure, when we talked about hypercapnic issues, a lot of the times it's because of the way they're using their accessory muscles. See, it eventually all ties together. Maintaining the tube patency. We suction these patients, but we don't do it routinely. We need to figure out if our patient needs to be suctioned. So, how do we know if they need to be suctioned? We actually see stuff to suction. All right? And I'm talking about suctioning the mouth and suctioning the tube itself. And this is another reason why it's so important to understand how deep, marking how deep it is in your patient, because you're going to have suction equipment, and I don't think I have it here. Your little suction tube can go past this, okay? So if you have this tube sitting in here, and let's say this is your little suction, if you go past where the tube is, you can end up poking the mucosa, right? And if you over suction and poke that mucosa, you're going to damage it. You put them at risk for bleeding. They can aspirate on it. And our goal is to not do our patients any harm, not to make them die, right? So we want to see, when you suction a patient, what's happening to their O2 at the time? It's down. It's gone, right? So are we going to sit there and suction and be like, how was your weekend? Oh, my God, I went to Nolan's this weekend and it was so great. No. So you're not going to do that, right? You're going to in and out a few seconds. You hold your breath for a minute. See how that, So during that time when you're not getting any oxygen, again, what may you notice if your patient's on an EKG monitor? You might see some dysrhythmias happening, right? Because again, that heart's getting irritated because it's got no oxygen. So you might see some excitability, some dysrhythmias start to occur. So your O2 is going to be dropping. They might become more restless because their brain's not getting oxygen. So we only want to suction when they need it. If they're visibly having respiratory distress or if we see secretions. And then there's the open versus closed technique. Again, it's in your book if you want to look over it. Page 1616, table 66-8. The only difference right here is a closed technique, this picture. So there's the ET tube. There's your tube right there. It's hooked up to the ventilator. This is going to the ventilator right here. This part is your suction. It is hooked up to suction. It's like in a little bag. And so when you're ready to suction, you open it, you twist it. It's like a three-way valve. You twist it open. And then now through the bag, so you don't need to do it sterile because it's all a sterile component all of itself. You go ahead and stick the tube through, and then you suction out, and then you close it off. You guys learned sterile technique suction, right? In some level, 3 maybe? Yeah, I knew that. 3, you learn. That's when you put the gloves on and you actually disconnect them, and it's sterile technique. The benefit of the closed suctioning is that you don't have, it just makes less chance of having like infection occur. Because we talked about what's one of those big complications, the ventilator associated pneumonia. A big reason that they get it is because of they're not sterile when they do suctioning. Managing thick secretions. Again, we talked about this. We need to keep them hydrated. Humidification. You'll see that on the vent. They have a little humidifier on the vent that supplies humidification. Keep it moist. Do we put saline down the trach or the ET tube? Okay, we used to a lot. So if you're an LPN and you've been working in the past, you might have seen. When I first started nursing. I sound like an old person. When I worked, I've only worked ICU and ER, and we used to in the ER at Tampa General, we would squeeze in Shands too. We'd put saline down to loosen up any thick secretions and then suck them out. We are going to increase risk of aspiration with that, okay? So we're basically just putting fluid in their lungs, which we don't want to do. So we don't ever put saline down the ET tube. I tell you guys about it because you might see some, I don't want to say old school nurses, but you might see it happening, and you shouldn't. Antibiotics, because if it's thick, it might just be because there's some kind of infection. So again, we send off cultures, we start them on broad spectrum. Mobilization, CPT, get the secretions moving. Oral care. This patient's mouth is always open, right? They're sitting there like that because you put a bite block in them and you have a tube in there. I get dehydrated just talking for 4 hours. Like my mouth feels dry and cotton mouth. So imagine these poor patients that are sitting for days with their mouth open. So you need to take really good care of their mouth because it increases the risk of infection if you don't. And it's just kind of decent, right? Human decency. So how good does it feel like in the morning to brush your teeth? That feels awesome, right? So brush the teeth twice a day. And in addition to that, we use those oral swabs with the hydrogen peroxide or the chlorhexidine rinse. Provide moisture to their lips, so chapstick or some kind of Vaseline, so that they don't get dried out. Because again, if they get dried out, and you have this tube sitting up against the lip. So if you have a dry, cracked lip and you have this tube putting pressure up against that lip, they're going to get ulcerations, they're going to get breakdowns. I've seen patients get disfigured because nurses don't take good care. I have seen patients lose a complete nair because the tube was sitting up against the nose and no one ever bothered to change position or take care of it, and the mucosa broke down so much. You'll see big ulcers in patients when they're not taken care of. A lot of complications that happen with patients are because we're not doing our job. So again, this is why I say these are the little things that are the big things for these patients. They're going to determine how many complications your patients end up with and how well your patients do. Suction the mouth, because again, we talked about they have these secretions coming down. Well, what happens if the tube breaks or the cuff breaks? Where are all those secretions going? Down into the lungs, right? What if you're going to do some trials to see if you're ready to extubate this patient and you deflate the cuff? Where are all those secretions going to go? Down the lungs, right? So we want to make sure we suction the mouth out. And we have to reposition and retape the ET tube every 24 hours and as needed. So what you'll typically do is, it's normally done during the daytime. Why don't we do it at night? There's not not as many staff, right? At night? Did you say more respiratory staff?
Said lower respiratory.
Oh, no. Well, I thought you said more respiratory staff, or less respiratory staff. So, yes.
Are you gonna need a doctor's order to reposition the ET tube?
Nope.
for oral care?
Nope.
Okay, something that they do is that.
Yep. Repositioning and redoing that's nursing care. Okay? Now, if you're kind of repositioning because you notice it's at 21 and it was marked at 20, if you inserted a little bit more, then that's typically okay. But if you're making big changes of like, up and down, then you have to get your doctor involved. But most of the time, it's just you're checking. I worked ICU for a long time. I rarely saw it be off than more than just a half or one marking. You're just kind of making sure it's in the right place. Yes.
Is it like a pig, if it comes out, you can't push it back in, or?
Yeah, if it comes like more than like one, if it's a significant difference, you need to call your doctor.
Are they gonna take it out and replace it, or?
They may reposition it, but I wouldn't take that risk. I would be getting, and again, you're going to be in an ICU. Like, as a nurse practitioner in the ICU, I didn't leave the ICU. I was available. Like, your intensivists are there on the floor with you. It's not like on the floor where you have to, there's not a doctor always on the floor. When you're in the ICU, there's typically always some kind of advanced practice provider or a physician assistant or nurse practitioner or a physician there. So, but again, your job is to reposition and tape this every 24 hours or more as needed. So again, if all of a sudden you have your patient's respiratory distress, then I'm going to see, okay, is my tube patent? Do I suction? Is it the vents, so I'm going to untape them and re-get my tape. Am I going to untape them and then get all my tape ready? No, I'm going to get everything ready. And then I'm going to get my friend Michelle, and we're going to come on in. And Michelle's job is to hold that tube. That is her only job. Because if that patient coughs, where's that tube going? Right out. If that patient, if we hit the gag reflex, it's going out. If they are not sedated all the way and move, it's going out. That they were trying to do a trial vent on my mom, so they wean sedation. That's typically what we do a lot. Hello. So we do a weaned extubation a lot to see if they're going to tolerate it. So what the therapist did is they kind of loosened the ET tube on my mom, and they weaned sedation, and she went wild, right? Because they're scared. So I remember having to get on my mom and just hold the tube while they tried to retape it. So you never, ever, ever want to untape the tube or play with it unless you have someone there to help you hold it in place. Okay? So Michelle's going to hold it in place. I'm going to gently rotate it to the other side, and then we're going to tape it. So again, because we don't want to have those ulcers. If we had kept the tube in the same place the entire time, there's that constant pressure, and that's when they develop those ulcers. All right, fostering care and communication. Yes.
So if it's nasal, how would you?
If it's nasal, it can be up. You can put it down, tape it down low. You can tape it to the side, but you can move it around so that it's not resting on the same part of the mucosa the whole time. You won't see those as much, but you can move it around so that it's not putting pressure. So not only are the patients anxious, who else is anxious? Family, right? Because they don't know, is my family member in pain? Are they hurting? Do they want something? I don't know. So we need to provide them a lot of different ways to communicate. We always think of sedated or vented patients as sedated, but there are a lot of vent patients, especially in your rehabs, that are wide awake. This is my mom. So see, she was still vented at this point. This is when she got a trach. So she did get better for a little bit. And my daughter would come, and she loved it when my daughter got. So that would really, because that was her first grandbaby, and don't tell my sisters, it was her favorite. So I don't care what they say. First grandbaby's always the favorite. So, and she was a girl. So my daughter would come, and my mom and daughter would write notes to her. My mom's blood pressure would decrease, her heart rate would go down, she required less pain medicine when she was able to sit and write notes with my daughter back and forth. So fostering that communication is really important. Again, you guys forget, or we want to do these big life-saving measures, but it's these small things that are going to prevent complications and help our patients. All right, suctioning. We talked about this, right? We talked about this in depth. So when we're suctioning, what's happening to our O2? Going down. We bronchospasm, right? Those airways are kind of clamping down. What do we do to the ICP? Increases, right? We cause the dysrhythmias. We can cause, that's what I was talking about with the mucosal damage. I guess I got ahead of myself, sorry. When we suction, and we stick that suctioning tube past where the ET tube ends, that's where we get that mucosal damage. So we can cause bleeding, pain. That's when we get infection. That's that ventilator-associated pneumonia that we get. So it's always important if we're going to be having to suction a lot. We might want them on a monitor. We might want to give them a lot of oxygen before and after we suction to make sure we don't cause any dysrhythmias. We're going to know on our tube how deep it is so that we're not sticking our suctioning equipment too far down. Unplanned extubation. So another complication. So when this happens, obviously, what are some signs and symptoms we're going to see? Your patient starts talking to you. If your patient is talking to you and they were intubated and vented, that is not a good sign. That means that they've pulled that tube out, okay? The alarms will probably be going off at that point. They're not going to have good breath sounds. Now, some patients are awake enough, and maybe we're doing a trial. You know, we've decreased sedation. We're trialing to see if they're doing okay, and they pull the tube out. They might do okay. So then we're going to listen. Okay, you have good breath sounds. Are you having any signs or symptoms of intolerance, like respiratory distress? They might get gastric distress. Why do you think they're going to get gastric distress? Or distension, right? Because if they pull the tube out, but pull it out, maybe they put it in the esophagus, and now we're ventilating the esophagus, which is ventilating the stomach. What happens if we blow that stomach up with air? What are they going to do? Barf, right? Yeah, throw up. So, and then they're at risk of doing what with that throw up? Aspirating. Crap. Now we just did, right? We just made it worse. So, most important things, if you walk into a patient's room and it's alarming, if they're talking to you, if you suspect that they have unplanned extubation, if they've pulled out their tube by accident, you are immediately going to start bag valve masking them, okay? Because if they have done it without us, they're probably not ready to be extubated. Sometimes they do okay, they self-extubate and they do all right, but most of the time if they have self-extubated themselves, they're not ready to be, and we need to provide them the oxygen. So we're going to bag valve mask, we're going to call for help, and we're going to stay with that patient. Doc's going to come in and he's either going to say, let's monitor them, let's see if they have any signs of respiratory distress, or he's going to say, let's prepare for reintubation.
Does this happen a lot?
It happens enough, yeah. I've seen it several times. Yeah. Yeah. You'll be surprised. I mean, sometimes they're just totally fine, and they'll be like, "I took my tube out," and you're like, "Oh my God!" But and most of the time, it's not that bad, but they're alarming. Or they self-extubate just enough, like they're not fully awake, but they're awake enough that they start thrashing, and they dislodge the tube just enough. So we gotta make sure that our ET tube is secure. That's why we do a good job. That's why we always have how many nurses changing? Two, because we don't want to be, I don't want to be the reason it comes out. I don't want that on me. So we're gonna make sure we have 2 nurses in there to change. We're gonna make sure that we secure it good with the method that we use, the tape, right? Make sure we have a good secured airway. We're gonna support the ET tube during any procedure. So when we're turning a patient, are we going to turn the patient with an ET tube without any help? No. We're going to have someone there that their job is to hold the ET tube while I turn them to the side. We're going to make sure they're sedated properly, because if they're not sedated properly, they don't have the right amount of pain meds. It's scary having this tube in their mouth. And if necessary, we use restraints. Restraints needs what? The order, right? And has to be renewed every 24 hours. Okay. Aspiration. This is what we talked about right up here. We want to protect that airway. It happens when we don't protect it. Again, we have increased saliva. So we need to make sure we suction out that oral cavity. If they're vomiting, we need to make sure we have an NG in, decompressing that stomach, because that's going to increase their risk for aspiration. And we keep the head of the bed what? Elevated. Yeah, 30 to 45.
What's LIWS?
Low intermittent wall suction. So those are all things regarding the tube itself, the artificial airway. If you have an artificial airway, you probably are on a vent. Okay? So now we're going to talk about the vents themselves. The vents are not curative. Again, most of what we talk about, when we talk about MODS, SIRS, DIC, ARDS, they are not disease processes themselves, but a symptom of some underlying condition, right? So a vent is not going to cure your patient. It is supportive care until we figure out what's going on and make the respiratory distress better. So what's normal FiO2? 21%. So we are going to provide FiO2 through the vent, and we can give them 21%. We can give them room air. That's the goal. But we can also increase the FiO2 to help when they're in distress. So that's when we were talking about that PF ratio. Which one, Luther?
He's read the whole thing.
Oh, okay. You got it? Oh, it's okay. And again, why do we use this? All the things we've already talked about. They're not breathing. They're in respiratory failure. They're hypoxemia. They have muscle fatigue, so they just can't keep up with their, demand. The supply can't keep up with the demand. And are there times that it's ethical not to use it? Yeah, but we're not an ethics course, so I'm not going to get into that. But this is when we talked about in test 1, when we need to know advanced directives. You need to know if your patients want this. Because once it's in, it's hard to take out. All right? But if a patient has a DNR, they'll specify maybe they want compressions, but they don't want to be intubated. There's a difference, and that's where you talk to your family members, you yourselves know what you want and what you're willing to have. All right. There are lots of different types of ventilation. You guys are not respiratory therapists, so we don't want you to be respiratory therapists. In the big umbrella of ventilations, there is negative pressure and there is positive pressure. You rarely see negative pressure. Negative pressure is they use it in a chamber that kind of encases the body. You typically don't have any kind of artificial airway. They put them in those like barometric chambers and they cause negative pressure. You're not going to see that a whole lot. What we're going to focus on is this positive pressure right here. And positive pressure can be either volume or pressure controlled. So positive pressure delivers air into the lungs during inspiration. So remember we talked about ARDS, we talked about that alveoli, and it's that stiff old balloon that's not going to inflate, not like a nice new balloon that opens up nice and big. So what that positive pressure does is that when the patient takes a breath in and that alveoli inflate, it provides a little bit of pressure. Because why do we want that pressure? It helps improve what? The surface area for what? The gas exchange. When they exhale, that happens just passively. The ventilator doesn't do anything when they exhale. So it's only when they're taking a breath in that the ventilator does anything. Yes. So a CPAP and a BiPAP are non-invasive. They do positive pressure, but they don't have an artificial airway in. When you do CPAP or BiPAP, it is the same idea. You just are wearing a mask. So a lot of people who have sleep apnea at night, they'll go ahead and put them on a CPAP machine. And when they're at nighttime, when they take a breath in, it will provide either a certain amount of volume or a certain amount of pressure. And we're going to talk about the difference between that. Yes?
But, I mean, it is, not to, it is different than a CPAP, though, because
No.
CPAP is more continuous, because even when you're relaxing, it still keeps your bronchial open.
But
So, I mean, then, wouldn't it become like a vent, because a vent lets you obviously have that exhalation?
do your alveoli ever collapse during exhalation? No.
I mean, CPAP is more like, it's internal pressure.
Yeah, because we're going to talk about it. There's a difference between whether they're supplying volume or they're supplying pressure. But it's still, during inspiration, they're supplying positive pressure. Yeah, it's just whether you're getting it like through an artificial tube with a mechanical ventilation or whether you're getting it through a mask. And there is difference. They can provide it continuously. They can do it in spurts like with the BiPAP. But regardless, during inspiration, positive pressure is supplied. All right, so it can be, like I said, volume or pressure. So when you have volume, positive pressure, the amount, the tidal volume is constant. The pressure varies with each breath. So no matter what, every time the patient takes a breath in, they are going to get the same amount of volume. Whatever it is, 5, 10, whatever. The amount of pressure it takes to open those alveoli varies. So with one breath, they may only need 5 centimeters of pressure, but the next breath they need 10, right? So that varies. But no matter what, they're going to get that same volume. Yes?
That's the peak number going up and down, or?
No.
No? Okay.
It's similar. Hold that thought.
Okay.
We're going to get there. It's just basically you're getting a same amount. I'm using arbitrary numbers, so that's why I guess I don't want to confuse you.
You're not, I'll just keep listening.
Yeah. You're always getting the same amount of volume. And this is where we talked about barotrauma. If you're always providing the same amount of volume, you have to be careful because what can happen if that lung, if that alveoli can't open all the way and you give it can tear open, right? That's where you get that trauma. But the pressure it takes to open that alveoli, to give it that volume, varies.
What measures the variance?
What measures what?
The variance of pressure required to open the alveoli from breath to breath.
the machine will
Machine.
determine, yeah, it will just determine how much pressure
So it can
resistance it has.
auto-regulate the amount of pressure.
Yeah.
Okay.
Okay? So pressure, positive pressure, is meaning the pressure is constant. It always uses the same amount of pressure. But the volume varies each time. So sometimes it may only give you, and again, these are arbitrary numbers I'm using. Sometimes it may give you 5, and sometimes it might give you 10. But it always uses that same amount of pressure to open that alveoli. So every time that pressure is going to be opened, but depending on how much volume the lung needs. And again, the machine kind of reads that. And you guys aren't respiratory therapists, so just understanding the basic concept of it is what we want you to know. And if you have time, those ventilator workshops will go, like, take this and show you on the machine what they're talking about. So it's a good visual, because I don't have a vent to show you. So these settings, there's lots of settings. You're going to see this machine, it's going to have a respiratory rate. It's going to have a tidal volume. It's going to have FiO2. It's going to have the PEEP, the IE ratio that we talked about. What's normal IE ratio? 1 to 2, right? So it's going to have all these different settings, and the nurses and the doctors are going to use a whole slew of information in the respiratory therapist. So they're going to get ABC or ABGs. They're going to get the level of consciousness. They're going to see how well the patient's able to use their accessory muscles. And they're going to titrate all of these based on that information. There are like 712 modes, I feel like, okay? And your book will address each of them. There is a table on page 1620, table 6612, that addresses all these different modes. And it's all based on how much work of breathing the patient should and can perform. How much help does the patient need? And again, that's all determined by their respiratory drive, their ABGs. So if someone has good, they take nice deep breaths, right? They have good volume, they have good pressure, but maybe they had a head injury, so their respiratory rate is low. That's going to determine, maybe we're not going to have their volume set really high. Maybe we're not going to have their pressure set really high, because they're doing a good job with that. But their respiratory rate is low, so we need to increase it. So we're going to set the respiratory rate at 15 or 16 to make sure that they're blowing off enough CO2. All right? Or maybe it's a different reason. So it's all varied and based, and there's a whole, each patient's going to be separate and different. And again, you guys aren't respiratory therapists, so we want you to apply it to kind of the respiratory distress ARDS.
Dr. Lewis, Dr. Daniels.
That's okay.
Your respiratory rate's low, so you increase the peak or increase the vent, or just.
No, I was just giving a general example. Yeah, like that if the respiratory rate was low, then you would increase the respiratory rate on the machine. Yeah. So this is where PEEP comes into play. This is what we were talking about with PEEP, that positive end expiratory pressure. It's the pressure at the very end. So normally you breathe in and the alveoli open up, and they exhale and the alveoli collapse, but not all the way, right? So if they're a nice big balloon and then they collapse, what the PEEP does is keep it open like here, okay? Keeps it open just a little bit longer so that we can have that gas exchange happening. So again, we said physiologic is 5. And this is where it's applied during exhalation, right? Because normally when we exhale, we blow out and it collapses. So we're providing pressure at the end of exhale so that we can keep it open. This is not during inspiration. This is during exhalation. So it prevents the alveoli from collapsing, which increases the FRC, which is the functional residual capacity, which is a big fancy word for gas exchange. and it improves the oxygenation, right? The longer we can keep those alveoli open, the more chance we have for that gas exchange to happen. So, can you have O2 toxicity? 100%. That's why we really don't like to see O2 sats of 100%, because do we know if that's 100% or if it's 140? No. When you're measuring a pulse ox and it reads 100, that's the max number it can read is 100. So you don't know if you're actually at 100 or at like 120, 100 million, right? So that's why we want to provide the lowest amount of oxygen to maintain the SaO2 greater than 90, because we don't want to give too much oxygen and create toxicity. I actually rather have an O2 sat of 99% than 100, because I know exactly what I'm giving them or what they're doing. So it helps to provide, improve O2 by reducing their risk for toxicity, because we're not having to throw a bunch of oxygen at them. You can't use it for some things like COPD. If they only have one-sided lung disease, you can't do this, because if you provide PEEP on one side, if you increase the PEEP, you're increasing it on both sides, right? If you only have a problem on one side, you're going to cause issues on the normal side. So it's got to be an issue on both sides. COPD, why do you think we don't really use PEEP with COPD? What? Yes. They have a hypoxic drive, but COPD, again, remember you don't want to over-oxygenate them. They have that hypoxic drive, and they're really non-compliant lungs, right? So if you're trying to keep them open, you might just crack them open or pop them open. Why are you going to be careful with decreased cardiac output? Remember, we talked about that. If this is your artery, right? And this is your normal alveoli, okay? If I'm increasing PEEP, now I'm taking my alveoli and pushing in to my pulmonary bed, and I'm putting pressure on it. So I'm decreasing the cardiac output. If I have somebody who's already got low cardiac output, am I going to contribute to that? No. So if I have a patient, and again, this is where you need to understand, you have your patient, and the doc says, you know what, they're not doing well, I want to increase the PEEP to 10, and you as the nurse say, hey doc, I want to be careful with that because their blood pressure was low today, and they're having decreased urine output, which probably means that their kidneys aren't getting as much perfusion, so I'm worried about their cardiac output. Do we really want to increase the PEEP? Because you're going to be at the bedside. So you see how you're going to tie those things together? So you're going to titrate because you want to improve O2 without decreasing cardiac output.
What's FRC?
FRC is the functional residual capacity. It's basically what you got left in there for gas exchange. It shouldn't take this away, but I have to stop the recording.